Good afternoon. My name is Nissen.
Okay, we can do this one.
All right, nothing to disclose. Again, the evolution of technique in surgical distal pancreatectomy, of course, involves laparoscopy and robotic techniques. And we look back at my personal 10-year experience at Cedars-Sinai on distal pancreatectomy, minimally invasive distal pancreatectomy, just to look back to see what the trends are and our outcomes. This slide is a little bit wordy, but you can look at the 10-year time frame. We label these as totally laparoscopic assisted, and robotic. And of course, laparoscopic assisted, the way I do that is typically a small hand port incision in the mid-abdomen, and then the laparoscopic portion is the tail of pancreas mobilization and splenectomy. And I've advocated this for a long time because it allows you access to the central vessels. It allows you good manual control of tumors. It allows you to make sure you have a good posterior clearance if you had an adenocarcinoma. And that laparoscopic assisted, or if you want to call it hand assisted, you can call it that, approach has been something we've advocated for a long time. Over that 10-year time frame, we've done 159 distal pancreatectomies, 30 of these totally laparoscopic, 85 laparoscopic assisted, and 45 robotic distal pancreatectomy. Interestingly, we really found no difference in we had no difference in type of BMI, in age, no difference in length of hospital stay, fistula rate, mortality, morbidity, and the one bullet point here, item 5, pancreatic adenocarcinoma did have a longer length of stay than the other diagnoses. This just shows the evolution of time over of our modalities. And again, the print is a little bit small. Lap-assisted is blue, totally laparoscopic is orange, and robotic is gray. Unlike most programs, we're moving towards robotic approach. Fewer and fewer laparoscopic assisted approaches. It's interesting, robotics really has, at least in our experience, really has replaced the need for a hand-assisted technique because of the instrumentation and the ability to obtain wide clearance margins. This is a slide simply showing the evolution of our own robotic practice. And this is all kinds of procedures. And again, it's a busy slide, but it shows you that over this last several years, we've added pancreatic odoronectomies, distal pancreatectomies, bile duct resections. And I put this slide in simply to show that as your robotic experience grows and as your comfort with different approaches of robotics grows, it's natural that it's going to replace our approach to distal pancreatectomy. And in fact, that's what's happening in our program as well. Our actual number of robotic distal pancreatectomies is shown here by quarter. And so you can see as a little bit of a blip in the mid, but over time, really our entire practice has now moved towards robotic distal pancreatectomy. What we're finding is that proximity of the tumor to the central vessels is no longer a need for a lap-assisted approach. It now can be handled very nicely with a totally robotic approach. Proximity of the tumor to the splenic artery takeoff to the celiac artery is no longer a contraindication to robotic or minimally invasive. All of that can be handled very nicely with the robotic approach. And again, the visualization, the instrumentation of robotics, I think will really push this field completely towards a robotic approach. So that's the summary of our 10-year experience with, which again, I think, as in many programs, is moving completely towards robotic and away from hand-assisted or laparoscopic assisted, and fewer totally laparoscopic. Thank you.
Thank you. Again, probably one question from the audience. If not, this is excellent. I think just what was maybe just learning a little bit about your pathway to robotics? You know, when was that? What was sort of the training and the proctoring? Kind of what was that?
Well, you know, about 5 years we've been evolving, and lap choles, and sort of course, we all know there's sort of a need to do it. You're driven by a variety of pressures, even market pressures. Lap choles, moving on to distal pancreatectomies, moving on to bile duct resections, and now Whipples. And I think that's a natural progression. And I think distal pancreatectomy is the perfect training ground for fellows. These are cases that senior residents and fellows really can learn how to handle vessels, how to handle parenchyma, and how to handle spleen, and how to handle tissue very nicely. And it's a true HPB case. So the distal pancreatectomy robotic is the perfect training ground for fellows and senior residents in robotics, I think.
Just want to add a quick comment. Sorry, I'm Emmanuel Shapiro, formerly trained by Dr. Secondio in San Diego. I totally agree. And the other thing is, I think you highlighted a point, which is you're not going to be doing the complex robotic hepatectomies and Whipples unless you start with the robot gallbladders and then distal pancreatectomies. And people, when they start off, they'll be like, well, why are you using a robot? You can do this laparoscopically just fine. Yeah, maybe, but you can do them MIS far more often robotically. And then the other thing is that builds up the skill set to do a robotic Whipple and hepatectomy, and you're never going to get to the real reason for the robot, which is the complex Whipples and hepatectomies, unless you start off with the gallbladders and the distal pancs first, which like hospital administrators and insurance companies don't recognize. They're like, well, you're doing it for basic stuff. Well, yeah, basic stuff first, and then build ourselves up.
Totally agree.
Erin Gilbert, Portland, Oregon. So in regards to your last talk, I apologize if you said this, but did you have an interim laparoscopic Whipple period, or did you go open to robotic?
Yeah, never did. Really was never a fan, never had any interest in it. We were doing Whipples through, 4-inch incisions because we were using this kind of hand-assisted thing.
Next one after this.
But again, as our former speaker, or the prior question, the distals, choles, other things allowed us to jump to the robotic Whipple, but never went through laparoscopic
Great, thank you
Whipples.
for clarifying.
Totally.
Thank you. Thank you both.